Welcome to the deep dive. We're tackling a subject today that, on the surface, might sound like it's straight out of a medical textbook.
Right. The anatomy of the rectum and anal canal.
Exactly. But when you really get into it, you find this incredible high-stakes map of survival.
It really is.
And just so everyone's clear, all of our material today, all the specifics, are drawn directly from Dr. G.S. Raju's YouTube channel. It's a fantastic resource for this.
It's an excellent breakdown because it goes way beyond just, static diagrams.
Yeah.
And honestly, for a piece of the body that's only, 15 to 17 centimeters long, the functional density is just incredible.
It's not just a tube.
No, not at all. It's
No.
more like a series of, physiological border crossings.
That's the perfect way to put it. That was the aha moment for me. We think of the GI tract as this long, continuous pipe, but this last stretch, it's like a series of airlocks. You have these zones where the rules of biology just completely flip.
The cellular structure changes, how you perceive pain changes.
Even how the body handles an infection. It all changes based on where you are.
Precisely. And for doctor, being able to visualize this anatomy isn't just about, passing an exam. It's about navigation. Dr. Raju presents it as this vertical map where one landmark can be the difference between a simple procedure and a surgical emergency.
A decision tree built right into the tissue.
Exactly.
So our mission today is to build that mental GPS for you. We want to visualize this 15-centimeter journey up, identifying the safe zones, the danger zones, and the coordinates doctors use.
And I think we should start with the most structurally significant boundary, the real containment wall, so to speak.
You're talking about the peritoneal reflection.
Right. And this one can be a little tough to visualize because it's not really inside the tube. It's about what's happening on the outside of the rectal wall.
Okay, so set the scene for us. The rectum has an upper half and a lower half.
It does.
But they're not in the same environment, are they?
No, not at all. So this peritoneal reflection, it's a membrane, and it only covers the front and sides of the upper rectum.
Just the upper part.
Yeah. The lower rectum sits entirely below it, deep down in the pelvis. And that distinction, it is the single most critical factor when you talk about perforation.
Okay, so this is the why it matters part.
Yeah.
If you get an injury, a tear, maybe from a procedure,
The perforation, yeah.
the outcome is totally dictated by whether it's above or below this membrane.
Let's run through the scenarios Dr. Raju lays out. So scenario A, you have a perforation, but it's in the lower half of the rectum.
Below the reflection.
Right, it's below it. So because that area is effectively outside the main abdominal cavity, any leak is contained.
So it's a local problem.
Exactly. It doesn't lead to what's called free peritoneal contamination. Now, it's still serious, obviously, but the way it's managed is completely different.
Meaning you might not have to rush to the operating room?
Often you don't. These can be managed conservatively. Watch and wait. Antibiotics. You let the body heal because the infection isn't spreading freely.
Okay, now contrast that with scenario B.
Scenario B, a perforation in the upper half of the rectum, above the peritoneal reflection.
Now you've breached the hole.
That's a great way to put it. A hole there opens directly into the peritoneal cavity.
Oh, wow.
So you have stool, bacteria, air, all spilling into the sterile environment of the abdomen. And that leads to peritonitis.
Now, peritonitis is a physiological five-alarm fire.
It is. Dr. Raju is very clear on this. This requires emergency intervention. There is no watch and wait with free peritoneal contamination. You have to go in.
So just based on location, a few centimeters higher or lower, you go from observation to emergency surgery.
That's the power of the peritoneal reflection. It's an invisible line on an endoscope, but it's the difference between a contained event and a catastrophe.
So that covers the structural risk. But as we move down this map, we hit another landmark, one that really defines the patient's conscious experience. The dentate line.
Ah, the dentate line. It's fascinating. It's basically an embryological collision point.
A collision.
Yeah, it's this jagged border where the rectum, which comes from one type of embryonic tissue, meets the anal canal, which comes from another. Functionally, it's the boundary between two different nervous systems.
This is where the cell type just completely shifts. Above the line is the rectum.
Columnar mucosa.
And below the line, the anal canal is lined with what the source material calls squamous epithelium.
Which is, for all intents and purposes, it's skin. It's a modified skin, but it acts like skin.
And it has the nerves of skin.
That's the key. It has a rich somatic nerve supply.
Meaning it is incredibly sensitive.
Acutely sensitive. It feels touch, temperature, and most importantly, pain. A cut or a tear below that line. The pain is sharp, it's localized, it's intense.
The body is designed to protect that exit point.
Aggressively. But then you cross that little jagged border, just a few millimeters up, into the rectum itself.
And the rules change again.
Instantly. The rectum lacks that kind of somatic pain sensation. It's run by the autonomic nervous system. It can detect stretch.
Which is how you know you have to go to the bathroom.
Right, but it doesn't feel a cut or a pinch in the same way your skin does.
And this has a huge practical application when you talk about hemorrhoids.
This is the classic example. We literally classify hemorrhoids based on this line. Internal hemorrhoids are above the dentate line.
And external ones are below it.
Right, at the anal verge. And this is critical for treatment, especially the banding procedure Dr. Raju discusses.
This is where they put a little rubber band on an internal hemorrhoid to cut off the blood flow.
Yep. It sounds simple, but think about the precision. The whole goal is to place that band on the tissue that is above the dentate line.
Because up there, the patient won't feel it.
Exactly. They might feel some pressure, maybe a dull ache, but not sharp pain. But the margin for error is tiny. If the doctor accidentally grabs even a little bit of tissue from below the dentate line,
You're lighting up all those skin pain nerves?
the source calls it severe pain and discomfort. It's immediate. It's excruciating. The entire success of the procedure depends on the doctor's ability to see that border and stay north of it.
Wow. It just shows the anatomy isn't just background info, it's the rule book.
It is. The exact same action, placing a band, can be a cure or agony, depending on which side of the line you're on.
Speaking of navigating, let's talk about the architecture inside the rectum. It's not just a smooth tube, right?
Yeah.
It has these shelves.
The valves of Houston, and it's funny, they aren't really valves in the way we usually think. They don't open and close.
They're permanent folds.
Permanent transverse folds that stick out into the lumen, the open space. There are typically 3 of them.
Inferior, middle, and superior.
Correct. And their main job, really, is to help support the weight of fecal matter. But for a doctor, their biggest role is as navigational waypoints.
They're the mile markers.
Exactly. When a doctor finds, say, a polyp, just saying it's in the rectum is way too vague.
Right.
So a report will say something like, there's a 5-millimeter polyp located on the fold of the middle valve of Houston.
So another doctor knows exactly where to go look. It creates a reproducible map.
It does, but they also create a challenge. These folds can create blind spots during an endoscopy.
Ah, so you could miss something hiding behind one.
Easily. Dr. Raju talks about having to sort of negotiate these turns. You have to look behind them to make sure you're not missing a small lesion.
Okay, so we have the peritoneal reflection for safety,
Right.
the dentate line for sensation, and the valves of Houston for location.
Yeah.
Let's put it all together on a ruler.
This is where it all clicks into place.
Yeah.
If we start at 0, which is the anal merge, the outside opening,
Right. We can work our way up.
we can. So you start at 0 centimeters, you move up through the anal canal. It's a short trip. Only about 3 to 4 centimeters long. So by the time you've gone an inch, inch and a half, you're crossing that critical dentate line.
So this super high sensitivity zone is really just that first little bit.
That's it. Once you pass 4 centimeters, you're pretty much out of that somatic pain zone. You're in the rectum proper.
And you hit the first landmark almost immediately.
You do. At about 5 centimeters up, you encounter the inferior valve of Houston.
Okay, keep going up.
At 8 centimeters, you'll find the middle valve of Houston. That's
Yeah.
usually the biggest one, a major landmark.
And the last one.
The superior valve of Houston is up around 10 to 11 centimeters.
And then it's just a final stretch before the rectum turns into the sigmoid colon.
And that transition point, the rectosigmoid junction, happens at roughly 15 centimeters.
So the whole journey from the outside world to the colon is packed into just 15 centimeters.
It's an incredibly dense piece of anatomy.
In the length of a smartphone, you've gone through sphincters, crossed a neurosensory border, navigated 3 shelves, and passed that peritoneal safety line.
There is one important caveat Dr. Raju adds about these numbers, though.
The variability.
Yes, these are averages. Biology isn't digital. He notes that these measurements really depend on the height of the person.
So a taller person would have a longer rectum.
Generally, yes. And a shorter person, a shorter one. So the 15-centimeter rule isn't absolute. It's a baseline. The landmarks are always in the same order, but the distance between them can stretch or compress.
So a doctor has to calibrate their mental ruler to the patient.
You have to. You rely on the visual cues, the look of the dentate line, the shape of the valves, not just the numbers on the scope.
When you lay it all out like that, what strikes me is the efficiency of the design, but also its vulnerability.
How so?
Well, the body has packed all these critical functions into such a tiny space, but because it's so condensed, a problem, like a tumor, creates a domino effect really fast.
That's a profound point.
A tumor at 4 centimeters is a totally different surgical problem than one at 8 centimeters.
It is. In other parts of the colon, you have feet of length. You have space. In the rectum, real estate is at a premium. And all the neighbors, the bladder, the prostate, the uterus, are packed right up against the walls.
Which brings us back to the peritoneal reflection. The lower rectum is extraperitoneal, which means it's buried in all that pelvic tissue.
And operating down there, deep in the pelvis, is notoriously difficult. It's a confined space. Whereas above the reflection, you have the open abdominal cavity to work in. The whole surgical approach changes just by crossing that line.
So if we just summarize the whole mission of this deep dive, it was really to visualize this map.
I think so. To see the rectum not as a simple tube, but as a structured environment.
We've identified the floor at the anal verge. We've marked the pain border at the dentate line, about 3 to 4 centimeters up.
We've climbed the ladder of the valves of Houston at 5, 8, and 10 centimeters.
And we recognize that safety ceiling of the peritoneal reflection, dividing the whole thing in two.
And finally, the exit door into the sigmoid colon at 15 centimeters. A complete anatomical story in a very short space.
It really changes how you think about even common procedures. It's not just going in and fixing it. It's a game of millimeters.
Where the stakes are pain, infection, and recovery. And it just highlights why expertise like Dr. Raju's is so valuable. Sharing these visualizations helps standardize that care. It helps make sure every clinician respects those borders.
It's about respecting the territory. The body has its rules, somatic versus autonomic, intraperitoneal versus extraperitoneal.
And good medicine is about navigating within those rules. You can't fight the anatomy, you have to work with it.
I think that's the perfect takeaway. Whether you're a medical student or just someone fascinated by how we're built, understanding these hidden thresholds gives you a huge appreciation for our biology.
It certainly does. It's elegant and complex and unforgiving all at once.
We're going to wrap it up there. And I want to say one last thank you to our source. All of the specific measurements and clinical insights we talked about today came directly from Dr. G.S. Raju's YouTube.
I'd highly recommend it.
Yeah, if you want to actually see what the dentate line or the valves of Houston look like through a scope, check out his channel. It really cements these concepts.
Absolutely. Seeing that texture change is worth the visit alone.
Thanks for listening to this deep dive. We'll see you next time.